बिस्मिल्लाहिर्रहमानिर्रहीम। अभी हम करते हैं हाइपरटेंसिव डिसऑर्डर्स ऑफ प्रेगनेंसी के ग्रीन टॉप गाइडलाइंस की समरी। यहाँ से स्टार्ट करते हैं। रिस्क रिडक्शन। एडवाइस करना है पेशेंट को टू सी डॉक्टर इफ सिम्टम्स ऑफ प्रीक्लैम्सिया, और हम उनको देंगे एंटीप्लेटलेट एजेंट 75 to 150 मिलीग्राम ऑफ एस्पिरिन ओडी फ्रॉम 12 वीक्स अंटिल बर्थ ऑफ द बेबी। एंटीप्लेटलेट एजेंट्स हमने किस में देने हैं? देयर क्राइटेरियाज, एटलीस्ट एक हाई रिस्क क्राइटेरिया हो या फिर ग्रेटर देन 1 मॉडरेट रिस्क हो। इन पेशेंट्स में हमने एस्पिरिन स्टार्ट करना है फ्रॉम 12 वीक्स ऑनवर्ड्स। 1 हाई रिस्क में वी हैव 5 क्राइटेरिया। उनमें से एक होगा दैट्स हाइपरटेंशन ड्यूरिंग प्रीवियस प्रेगनेंसी, पास हिस्ट्री होगी हाइपरटेंशन की, क्रॉनिक किडनी डिजीज होगा या पेशेंट को, या SLE होगा ऑटोइम्यून डिजीज, और डायबिटीज आइदर टाइप 1 और 2 एंड द क्रॉनिक हाइपरटेंशन। इन पेशेंट में एक भी अगर ये प्रेजेंट होगा वी विल स्टार्ट एंटीप्लेटलेट्स एस्पिरिन। एंड ग्रेटर देन 1 मॉडरेट रिस्क जिसमें फर्स्ट प्रेगनेंसी प्राइमरी ग्रेविडा होगी, एज ग्रेटर देन इक्वल टू 40 years, and as a pregnancy interval greater than or equal to 10 years, BMI greater than 35 at first visits, and as a family history of preeclampsia, family history, personal history नहीं, एंड मल्टीपल प्रेगनेंसी। तो इनमें से अगर कोई 2 क्राइटेरियाज होंगे, 2 मॉडरेट रिस्क, वी विल स्टार्ट एस्पिरिन, और इफ 1 मेजर क्राइटेरिया में से होगा वी विल स्टार्ट एस्पिरिन। फार्माकोलॉजिकल एजेंट डू नॉट यूज नाइट्रिक ऑक्साइड डोनर्स, प्रोजेस्टेरोन, डायरेटिक्स एंड लो molecular weight heparin for prevention, and nutritional supplements do not recommend magnesium, folic acid, antioxidants, vitamin C, E, and fish oil, algal oils, garlic, with aim of prevention of hypertension. Diet with salt restriction is only indicated in chronic hypertension but not in gestational hypertension or preeclampsia. Pre-pregnancy advice. Patient came with chronic hypertension for preconceptional counseling. Then all ACE inhibitors, patient taking ARBs or thiazides or thiazide-like diuretics, they increase the risk of congenital abnormalities, and we will offer the patient alternatives. Antenatal appointments, chronic hypertension, if poorly controlled blood pressure, we will do weekly appointments, and if well controlled BP, then every 2 to 4 weeks, depending upon the severity. Now intrapartum care, blood pressure monitoring, investigations, care during epidural analgesia, and second stage of labor management. Now blood pressure monitoring, mild to moderate hypertension, we will do blood pressure monitoring hourly. And if severe hypertension, we will do blood pressure monitoring every 15 to 30 minutes until BP less than 160/100. We will do hourly monitoring in severe hypertension. Investigations are same criteria as in antenatal period, and वो हम आगे पढ़ेंगे. And care during epidural analgesia, if severe preeclampsia, do not preload with IV fluid before epidural. एपिड्यूरल से पहले हमने उसको प्रीलोड नहीं करना है फ्लूइड में, जैसे हम स्पाइनल में करते हैं, ताकि वो हाइपरटेंशन में ना चली जाए। लेकिन अगर पेशेंट को सीवियर प्रीक्लैम्सिया है तो हमने पेशेंट को बहुत ज़्यादा IV फ्लूइड्स नहीं देना, पहले से प्रीलोड नहीं करना ज़्यादा। सेकंड स्टेज ऑफ लिवर मैनेजमेंट, कंट्रोल हाइपरटेंशन, डू नॉट रूटीनली लिमिट ड्यूरेशन ऑफ सेकंड स्टेज, अपने नेचुरल टाइमिंग में जाए। लेकिन अगर पेशेंट सीवियर हाइपरटेंशन है तो हमने उससे असिस्टेड वजाइनल बर्थ करना है, सेकंड स्टेज को हमने शॉर्टेंड करना है। नाउ मैनेजमेंट गाइडलाइंस आर द सेम फॉर क्रॉनिक एंड जेस्टेशनल हाइपरटेंशन। ब्लड प्रेशर हाइपरटेंशन 140/90 to 159/109. Admission to hospital, do not admit routinely if the BP is 140/90 to 159/109. And in severe hypertension greater than 160 to 110, we will admit that patient, increased risk of preeclampsia, eclampsia, health syndrome, and acute fatty liver. It's all included. For prevention of these severity, we'll admit the patient if the BP is greater than 160 to 110. Preeclampsia pathway hypertension 140/90 to 160/99. Admit if clinical concern. And severe hypertension greater than 160 to 110 will admit that patient. Initial management of a pharmacological treatment to all the patient with blood pressure above 140/90. इससे कम नहीं. First choice is labetalol, either oral, and if where we will give IV labetalol. Second choice is nifedipine, adult retard we give, and the third choice is aldomer, methyl dopa. Aim for BP should be of 135/85 or less. Blood pressure, once or twice a week we will monitor blood pressure of hypertension, that is 140/90 to 159/109. Proteinuria we will do once or twice a week. And in severe hypertension where BP is greater than 160 to 110, we will admit that patient. We will do monitoring of blood pressure every 15 to 30 minutes. And in preeclampsia pathway will at least every 48 hours or more frequently if needed. And we will do proteinuria only repeat if clinically indicated, and we will do the blood test, that is full blood count, renal function test, and liver function test at presentation. The patient come in moderate in mild hypertension and severe hypertension. If the BP is greater than 160 to 110, we will do the proteinuria test daily. And at presentation, we will do blood tests at presentation and then once a week. While in preeclampsia, we will do proteinuria only repeat if clinically indicated, and we will do the blood tests twice a week. If hypertension is less than 160 to 110, if greater than 160 to 110, that is severe hypertension, we will do the blood tests like full blood count, LFTs, and liver function tests 3 times a week. Fetal assessment. We will do fetal assessment, that is heart auscultation at every antenatal appointment, and preeclampsia at every antenatal appointment, ultrasound at diagnosis, and then every 2 to 4 weeks if clinically indicated, a diagnosis, and every 2 to 4 weeks, a diagnosis, and every 2 weeks, and cardiotocography if clinically indicated, and then severe hypertension at diagnosis, then if clinically indicated. In the same way, CTG, a diagnosis, then if clinically indicated, if maternal anxiety rate of reduced fetal movements, or if hypertension is where a patient had shown lab abnormalities, we will also do CTG to rule out any fetal distress and the need for emergency delivery. If dipstick is positive +1, we will quantify the proteinuria. If protein creatinine ratio 30 mg per millimole is diagnostic threshold, or if albumin creatinine ratio 8 mg per millimole is diagnostic threshold, we will interpret findings in the context of full clinical review, including symptoms, signs of preeclampsia, headache, visual problems, vomiting, severe pain just below ribs, swelling of face, hands, feet, etc. And other investigations such as evidence of hemolysis, abnormal liver function test, worsening of renal functions, and a falling platelet count. That's preeclampsia diagnosed. Or if there is no proteinuria, no clinical features of preeclampsia, we will do continued monitoring. If less than 37 weeks, do not offer planned early birth to women whose BP is lower than 160/110 mm of mercury unless there are other medical indications. And is greater than equal to 37 weeks, agree the maternal and fetal indications for birth and its timing between the woman and the senior obstetrician. We have to discuss that. We were there. Okay, we will offer full clinical assessment at each antenatal appointment. Admit to hospital if there are concerns for women and babies such as sustained systolic BP greater than 160 to 110. There are concerning maternal investigation, the signs of impending pulmonary edema, signs of impending eclampsia or severe preeclampsia, suspected fetal compromise, or any other clinical signs that cause concern. We will involve the scene of traditional any birth timing in women with preeclampsia, and less than 37 weeks consider planned early birth in women with severe preeclampsia, and greater than 37 weeks initiate birth within 24 to 48 hours after giving the steroid cover. Do not use first morning white to quantify proteinuria. Concerning maternal investigations include a rise in creatinine 19 micromole per liter or more, 1 mg per 100 ml or more, or a rise in ALT over 70 international units per liter, or twice upper limit of normal range, or a fall in platelet count under 1,50,000 per micromole per liter. Thresholds for considering planned early birth include inability to control the blood pressure despite using 3 or more classes of antihypertensives in appropriate doses, maternal pulse oximetry less than 90%, progressive deterioration in renal function and hemolysis or platelet count, ongoing neurological features such as severe or intractable headache, repeated visual scotoma or eclampsia or placental abruption. In all these conditions, we will considering plan for early birth. Offer antenatal corticosteroids and IV magnesium sulfate if planned early birth, because if there are signs of impending eclampsia, signs of preeclampsia, we'll give magnesium sulfate and we will deliver the baby within 24 hours. Fetal monitoring, ultrasound for fetal growth, amniotic fluid volume assessment, and umbilical artery Doppler ristometry. In chronic hypertension, we will do a 28, 32, and 36 weeks. In gestational hypertension, we will do ultrasound all these ultrasound features at diagnosis, and if normal, repeat every 2 to 4 weeks if clinically indicated. And cardiotocography will do only if clinically indicated in chronic hypertension, and gestational hypertension only if clinically indicated. In gestational hypertension with severe diagnosis, if conservative management planned, say by preeclampsia, will repeat ultrasound at every 2 weeks. And CTG will do a diagnosis. Do not repeat if CTG normal unless clinically indicated. Repeat CTG if the woman report a change in fetal movement. That's very, very important. Maternal concerns and vaginal bleeding, abdominal pain, signs of placental abruption, which happens in severe uncontrolled hypertension, and deterioration in maternal condition. We will do postnatal investigations. Postnatal is very important. In ward, patient is admitted because we don't have to discharge the patient immediately. If she's severe hypertension after delivery, we will admit the patient in postnatal ward for investigation, for the monitoring and treatment. Day 1 to 4 in chronic hypertension, gestational hypertension with a measure BP daily. And in preeclampsia, ask women about severe headache and epigastric pain each time BP is measured. Measure BP 4 times a day while inpatient and every 1 to 2 days for up to 2 weeks until patient is off treatment and has no hypertension. Day 2, stop patient taking methyl dopa and offer alternatives. We have to stop patient taking methyl dopa because methyl dopa causes postnatal depression and headache, and we will offer alternatives like ACE inhibitors, which are enalapril, is safe in breastfeeding. Day 2 to 3, 48 to 72 hours after birth in preeclampsia, we will measure the platelet count. We will repeat all the investigations. We will use LFTs, blood count, and serum creatinine. RFTs, if abnormal, we will repeat as clinically indicated. Day 3 to 5, we will measure BP once daily in chronic hypertension, gestational hypertension. While 6 weeks after birth, there will be medical review. We will refer the patient to general physician for appropriate antihypertensive, or if patient taking enalapril, we will ask the patient to continue. Critical care management of severe hypertension, preeclampsia or eclampsia. IV magnesium sulfate collaborative eclampsia trial regime. A loading dose of 4 gram IV over 5 to 15 minutes followed by infusion of 1 gram per hour, maintained for 24 hours. If the woman has had an eclamptic fit, infusion continued for 24 hours after the last fit. Recurrent fits treated with a further dose of 2 to 4 gram IV for 5 to 15 minutes. Do not use diazepam, phenytoin or other deconvulsants as an alternatives. Fluid balance and volume expansion. Do not use volume expansion in women with severe preeclampsia unless hydrolazine is an antenatal hypertensive. Cesarean section versus induction of labor. It depends on the woman's preference, and the more than woman preference, the clinical circumstances. Breastfeeding. Most antihypertensive medications that taken while breastfeeding only lead to a very small levels of breast milk. So the amount taken in any baby are very small, will be unlikely to have a clinical effect. Consider monitoring the blood pressure of babies, especially those born preterm who have symptoms of low blood pressure for the first few weeks. When discharged home, advise women to monitor the babies for drowsiness, lethargy, pallor, cold, peripheries, or poor feeding. Offer enalapril to treat hypertension in women during the postnatal period with appropriate monitoring of maternal renal function and maternal serum potassium. Overall risk of recurrence of hypertensive disorder of pregnancy is 1 in 5, and long-term risk, increased risk of hypertension, cardiovascular disease in later life. Thank you.